Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening and welcome to Pause for the Truth. I am your co host, Jocelyn Turner. It's a lovely, lovely day in Northeast Florida. If you are anywhere else, then you are missing a treat because I couldn't have asked for more perfect weather here today because it wasn't so steamy hot like it's been. But we have to savor the moment for the next few days because the steam and heat is going to come back by the weekend. But we hope everyone is having a fantastic Tuesday and had an even more amazing Labor Day weekend because we group it all together, Dr. Kane. We say Labor Day weekend, even though Labor Day was yesterday. We grouped it with Friday, Saturday, and Sunday. How was your Labor Day weekend, Dr. Kane?
I got some papers that had twos in there, but that's another story. The My Labor Day weekend was absolutely fine. I have to do like they used to do back in my day and just go, hey, hey, hey. If those that remember that program.
Telling your age, Dr. Kane, telling your age.
I got more than me telling age.
That-
Either
well, we
way,
are.
I am very happy to be here. I think it was an excellent weekend. The weather over here I'm a little bit over on the coast, so we had a few showers coming in and out, but they were welcome because the temperature was great. So I have no complaints whatsoever. The only thing that I'm looking forward to is talking to Dr. Sanders because she's our resident neurologist, and I couldn't wait for her to get back on and start talking about I'm not going to say a favorite subject, but it's one of those subject matters that I encounter every day, sometimes 2 or 3 times a day.
Mhm. Yeah, and since you let the cat out the bag, I was just about to ask Dr. Sanders to, first of all, to welcome her and to also say, Dr. Sanders, tell our audience a little bit about yourself. How are you doing this evening, first of all?
I am doing wonderful. Unlike, you guys that were spent all the weekend on the outside enjoying the weather, I did the opposite of laboring. I rested. I don't think I got out of my bed much over the weekend. So I feel refreshed. I feel refreshed today. But thank you.
Go ahead. I'm sorry.
What did you say? But I would like to thank you all for inviting me back, and I feel the warm welcome of being the resident neurologist here for Pause for the Truth. So thank you for bringing me back out. And as Dr. Kane mentioned, it is really about sharing more information about Alzheimer's because there has been a lot that has come out since our last discussion about a year ago. But I am a board certified neurologist with Baptist Neurology here in Jacksonville Beach. And I have been in practice for over 15 years. And so I've seen the evolution of neurology care, our ability to diagnose and now treat certain conditions that were felt to be untreatable in the past. So I'm excited about sharing some updates that we've seen in the management of Alzheimer's and dementia.
Yeah, and I'm glad you said that, Dr. Sanders, and welcome. Every time you come on, I learn so much about you, and this is a very important topic. So if you're just tuning in, we're talking about living with dementia, Alzheimer's, and can you start out by telling folks what's the difference and why do people tend to just group them all into one?
Oh, definitely. I do have a couple of slides. I forgot to mention that before that kind of
Okay.
pulled it all in together. Um, let's see here. There we go. So as we know, we hear the term dementia, and when we think about dementia, really for us, it is a neurological condition that affects the memory, the thinking, being able to process information and have some cognitive abilities that to do some of your activities of daily living. I think it's important to know that dementia is not a part of aging. We know a lot of patients or people who are in their 90s and 100 years of age and have very sharp memory. So to see a decline that is significant enough to impact your ability to function is really what we consider with dementia as dementia. But I think where a lot of the confusion comes into play is, do I have or does my loved one have Alzheimer's or do they have dementia? And we really need to think about dementia being an umbrella term and that there are many types of dementias. The most common type of dementia is Alzheimer's, and I think we'll talk a lot about that today. But there are other types of dementias that kind of differ in how they present and the pathology or the abnormality that's underlying the disease. So probably the next most common is vascular dementia, then frontal temporal dementia, and then there are many people that kind of have a mixed dementia. But this is different than the random forgetfulness, right? So we all go into a room and we can't remember exactly why we went into that room. If we backtrack and go backwards in our steps, we might remember, oh yes, I was going to get X, Y, and Z. And so when we think about dementias, and I think we joked about it before coming online, is that, you know, when you forget that you forgot, that's when we get, you know, really concerned about this being something more than just the aging process.
Yeah, and and this may be an inappropriate question, but it's just a thought. So, just other than walking in the room and forgetting why you were there, are there any particular signs that one may notice in themselves to say, "Oh, seems like things are changing with me. I might need to start paying more attention to this." Am I going ahead of myself? I'm sorry, Dr. Sanders.
You're good. No, I'm sliding right on in. Don't worry.
Slide right on in. Excuse the pun.
So Jocelyn, you're right. There are some signs and symptoms that you want to kind of think about. We always think about memory, right? Forgetfulness, misplacing things, but it is much more complex than that. Like people began having difficulties with making a decision, going through the cognitive steps to judge whether things are right or wrong. They get confused about times and places. And I hear all the time from my retired patients, well, I don't have a reason to keep track of time, right? I don't have a reason to know what day it is. But that is something that we want to look out for, particularly if people are missing appointments, forgetting to take their medication. So it's not just a forgetfulness, but what impact it's having on their function. But then we can see social withdrawal. So they're not wanting to engage with other people or have conversations. Oftentimes, people with dementia tend to become less vocal. They don't really have much to say, and they have difficulty with completing complex tasks. So we want to look for, if you are again seeing that you're forgetting to take your medications, you have difficulty communicating with others, or you're having difficulty making a decision about things that you did in the past, particularly finances, that's when we get concerned.
So let me ask. I have patients. I mean, I know the difference between the two, but some of my patients going like, how do I know if I got vascular dementia? Or it may not be the patient asking, it may be the family. How do I know if I got a vascular dementia, Alzheimer's dementia, or does it make a difference? Is what sometimes people ask.
So it does make a difference about the type of dementia, but sometimes it's very difficult to tease out which one. I generally tell people in my initial evaluation that dementia truly is a pathologic diagnosis. Like, we really don't truly know what type of dementia a person has unless we look at the cells underneath the microscope. Fortunately for everybody, we don't do brain biopsies and we don't take out brains to see. And so, because of that, we have to kind of get a glimpse or a view of what their symptoms have. Sometimes the dementias progress or get worse very differently. If someone has vascular dementia, sometimes they have what we call a stepwise decline. So they have kind of temporary periods where they're worse, maybe because they've had a new stroke or a TIA, and that worsens the memory and it stays there. And then it steps down at a future time with another TIA or another stroke. And so that's what we see with vascular dementia. With other types of dementias like Alzheimer's, we see kind of more of a steady decline. And it does make a difference in the type because there may be differences in the treatments for those types of dementias.
And
And
just
baby boomers. Oh,
for clarity's sake, TIA stands for transient ischemic attack, and that is
mhm,
where your brain, parts of your brain temporarily may not be getting the adequate enough blood supply, and temporary is just what it says. Temporarily,
mhm.
not enough blood supply, it comes back, and so does the memory, I guess, if there's any memory loss associated with it. But it may be indicative of more of a vascular related issue, obviously. And so I
Right.
just because we're talking to lay people, I have to make sure they
Mhm.
understand what we're talking about.
Definitely.
And Dr. Sanders, what are the earliest patterns you advise families to watch for? Boomers are getting older. Younger people may not be as knowledgeable about these things as we may get as we are get older. So, what do you advise families to watch out for, and what's the first clinical step?
So I recommend that families watch out for some of those same things. Is mom, dad, or grandma forgetting to take their medications, or they're not keeping up with their hygiene, so they're forgetting to take a shower or change their clothes. Probably the most significant one is, how are they doing when they're driving? Are they getting lost or confused about going to familiar places? I had a patient the other day whose daughter brought her in, and she was supposed to go to McDonald's, which is a 5-minute drive between her house and the McDonald's. And it took the patient 30 minutes to get to that McDonald's because she got lost and
Mhm.
started turning down streets that were going in the wrong direction. So those are the kind of things when we're following and tracking our loved ones, is how are they functioning and their daily living, because that's is what's going to tell us that this is something more than just forgetfulness.
Do you have difficulty convincing family members that it's not getting older or old age, but when in fact it is something else more serious, if you will?
I think Dr. Kane might be able to answer this a little bit better, because by the time they get to me as a
Yeah, they already
neurologist,
know. Yeah.
they already know and they're already concerned. Um, so I don't want to
Yeah,
punt it too.
Dr. Kane.
I'll go ahead. I dip in because, as a matter of fact, I can give you a perfect example. So one of the things that I run into is a lot of times the family doesn't realize A lot of times I see it in my office because that patient has missed an appointment several times and or they come up to the office multiple times to confirm that they got this appointment. I had one gentleman, he's an attorney and still practicing, and he would come up to the office, look like every other day, to confirm when his appointment is there. And when is his appointment? Luckily for me, I got an office staff that stays very alert on those circumstances. So they bring it to my attention because sometimes when they get to me, a good Alzheimer's, I don't want to say a good Alzheimer's patient, but Alzheimer's patients a lot of times can fake it with you for about 5 to 10 minutes. And you got to be aware, you got to be ready and start paying attention because they sound fine. Okay, they're taking their medicine, they tell you they're taking their medicine, and so on and so on. And so there's one particular patient, he can go up to he go out of his neighborhood, go to the right, then make another right into, within 500 feet, right into the McDonald's. And then when he comes out, make a left, and then he goes right back and make another left. And he's right back into his neighborhood. Problem is, somebody gets behind them, and like what Dr. Sanders said, sometimes they have difficulty processing stuff, particularly if it's presented to them too fast, and it may wind up confusing them, and they make the wrong turn. And as soon as they make their first wrong turn, a lot of time it's over from that standpoint. So,
Yeah, and the question is, once the diagnosis of dementia, what treatments are available to delay or treat the condition?
I think Dr. Sanders may have been coming with that over.
Are we going too fast, Dr. Sanders?
You're that's okay. I'm here, and yes, you're right. We will kind of touch on that once we kind of get a full understanding of what Alzheimer's is and how we make that diagnosis. Then we'll kind of transition into kind of the treatment. Um,
I'm glad you have the risk factors, because that was going to be one of my next questions. What are the risk factors of it? If you have other family members who've had it, are you now more predisposed to also having dementia?
Yes. So the biggest risk factor is age. Obviously, the older you get, the more likely you are to develop dementia. And so we commonly see dementias, and particularly Alzheimer's, occur above the age of 65. And that's in people with a family history or without a family history. But genetics definitely does play a role. There are some familial or hereditary forms of dementias, which this is not what I'm talking about. Those people develop dementias in their 40s, very, very young people. But there is something about the genetic abnormalities that predispose you or make you more susceptible of developing dementia. We talked a lot about vascular dementia a few slides ago, but I think there's also a risk for the vascular risk factors that do kind of accelerate Alzheimer's and those other types of dementias. And so that's looking at high blood pressure, high cholesterol, diabetes, obesity can be risk factors for having dementia at a later stage. And then lifestyle choices like drinking alcohol is a big one. And then there's socioeconomic factors as well, lack of access to healthcare, getting on the appropriate medications to manage those risk factors can play a role from that standpoint.
And people think of, well, if I have high blood pressure or diabetes or high cholesterol, I'll take the medication to manage those, but they don't think about the link or connection to other diseases like dementia. If you're just tuning in, we're having a conversation with Dr. Kalina Sanders, talking about living with dementia. She's sharing insights. She's a neurologist here in Northeast Florida. Continue posting your questions. How often do you get to have a neurologist one on one? I say one on one to really answer your questions because so many of us have relatives who are dealing with this. And Dr. Sanders and Dr. Kane, this is an ugly disease to me. You know what I mean? And someone just says, I have family that's in denial. And that is the case. You can have a 5-minute conversation with the individual and they seem okay, but extend it out to more than 10 minutes. And that's when you can start, it will start showing itself, if you will. But if you're not a person who is familiar with the disease, you just think, oh, great grandma or grandma just is just getting older. Um, how much
How
E
much alcohol?
That's a relative question. It's relative.
She didn't know what ETOH meant.
Oh, I was about to say, I don't know what ETOH mean, but thank you for breaking that down to me because a lot of people they get their adult beverages in, right, Dr. Kane?
Yes, yes, they do. So I don't think there's a specific amount of alcohol. It's individualized to particular people, but obviously, if it is something that you are partaking in on a daily basis, and likely to the point where it is taking the place of other nutrients and things that you should
Mhm.
be putting into your body, that's when it's too much.
That's why my screening comes in as a physician, as a primary care physician. I really screen in on that because when I refer patients to Dr. Sanders, I just want to kind of give her a heads up as to what we may be dealing with to a great degree because people that drink too much alcohol can also suffer significantly from a vascular dementia. And not to
Mhm.
mention, there can be a combination of both vascular and Alzheimer's related dementia. But I
What
digress. I'm going to leave it to Dr. Sanders for that.
what about gender? Is gender also, do you find it is more prevalent in women versus men or not necessarily?
There really isn't a gender difference for Alzheimer's. It's an equal opportunity disease.
Well, that's quite
DEI.
scary. And I've heard people to even say, what'd you say, Dr. Kane?
DEI.
Oh, listen at you. Dr. Sanders, I've heard people even say, I'd rather have my mind instead of my, the physical other part of the body because it's so watching loved ones who have some form of dementia. As I mentioned earlier, it's hard to watch it when physically the person looks fine, but when you have a
Mhm.
conversation with them, it gets difficult. And having had family members who've done it, fortunately, being in the public health field and knowing Dr. Kane and other physicians, I'm able to pick up the phone and have a conversation with people, but people just don't know where to go or what to do, and they're in denial, as the comment said. But I like that you brought up
Mhm.
lifestyle choices and socioeconomic factors because those are things, again, that people just don't think about or pay attention to. Talk a little bit more about socioeconomic factors as a risk factor for dementia.
So as I mentioned before, when we think about health, there are a number of different things that come into play. There are the biological factors, but then there are kind of what we've coined as the social determinants of health, and these
Mhm.
are the things that are around a person's everyday living that impacts their health. Many times for populations that are brown and black communities, there is access issues. So they have difficulty
Yeah.
accessing the right provider that they need to get to the right treatment options. Yes, they can get to Dr. Kane. He's in their community. They can get there to public through public transportation. But how about when you need to see a neurologist or have access to some of these more advanced treatments where you have to go to the beaches or to Mayo or somewhere else to get them, and you just don't have it, right? There's food insecurities. There's lack of physical activity because those resources aren't there. And the same thing with the mental exercises. So having access to crossword puzzles or books that kind of help you kind of keep things going. So those are kind of the social economic things. And then I'll throw in there insurance. So sometimes people are uninsured or underinsured, and that also impacts their health.
I'm glad you
I
mentioned
would,
the puzzles and things because I always like to remind people when you're talking about gift sharing, start sharing gifts that stimulate your mind. I
Mhm.
people laugh at me because I'm always now I'm not saying that it's a good thing, but I play Scrabble a lot on my phone. If I can't play with people in person, I go from Scrabble to some of the other games online. And to me, it just helps stimulate my mind. And also, Dr. Sanders, I tell this story all the time, throwing Dr. Kane under the bus. When I got ready to retire, the first thing he said, okay, what are you going to do now? Right? Because he shared that he's had patients who retire and they go home and do absolutely nothing, right?
retire to die is what I call
Yeah, and so and I'm thankful that he told me or advised me that you got to do something. You can't just go home and sit down. Okay, you can do that for a couple of months, but what are you going to do after that? So I don't know if you had some more slides you'd like to share before I
it.
continue to bombard you with questions.
Before she go down, only two quick points. You
Okay.
know, one is a mind is a terrible thing to waste. So if you retire and just do absolutely nothing, you wasting your mind. Okay, that speaks for itself. The second thing I wanted to do is elaborate on the role that excuse me that diet plays in dementia. Now, I'm not talking about what you eat at this point. We probably will talk about it maybe. I'm just talking about eating, period. A lot of times, some of the warnings that the relatives, the loved ones miss is why this patient's losing so much weight.
Mhm.
And I mean, that's one of the things I look at when I'm in the clinic, and a lot of them they lost all this weight. It's like, so why are you losing this weight? And I go searching for some obvious cause like cancer and stuff like that. But a lot of times I don't find it. And many of times, and I have relatives that I have to address that with as well, including my mother. That luckily for me, I got some siblings that are involved in it. That's a conversation for later. Uh, the trick winds up being they forget to eat, or they don't get access to the food that may fall up under social economic factors. But they don't get the food. Even when you get them food, they may forget to eat it. And because they forget to eat it, they start losing weight. And that might be one of the first signs or signals to the loved ones that I need to check out and make sure mom, sister, brother, son, daughter, whomever is doing okay. Dr. Sanders, I'm sorry.
No, you're right on. I agree. And as you're talking, I'm thinking about my own mom who's 82 years old in Texas, and I'll call her and I'll say, "Well, did you eat today?" And she said, "Well, let me see here."
What did I eat today?
Yeah, exactly. So you're right. Forgetting to eat is a huge sign that there is something going on. And I think that there was a question or a comment earlier on about kind of why does my loved one with dementia ask the same question over again, or forget to eat, or forget to take their medications. And I think it's important to there you go, thank you. What's the underlying reason when someone consistently repeats themselves? And that's the underlying pathology of Alzheimer's. So what is the problem that's happening underneath the surface, under the microscope? And so in people that have healthy brains, their nerve cells are there to communicate with each other, to help you learn new information and recall information. And so, what happens in someone who has Alzheimer's is they have an accumulation of these abnormal proteins or called amyloid plaques. There are a couple of other things that are involved as well, but this is the primary abnormality is these amyloid plaques. And these amyloid plaques kind of develop within the brain on top of nerve cells that prevents the communication from getting from one nerve cell to the next nerve cell. I always like to give like the analogy that you can think about these amyloid plaques like the debris in the road. And that debris in the road prevents you from getting to your neighbor's house or across the street or wherever you need to go. And sometimes over time, there's more and more amyloid plaques that continue to build up to the till it gets to the point where it's not no longer just slowing the process down, but it's stopping complete communication between one nerve cell to the next. And that's is why, especially with that more short term and immediate recall, our patients or people with dementia have difficulties. Now, some of the longer term memories, the important things that happened in the past, that's oftentimes the last thing to go. They can tell you all about the childhood. And that's because those are kind of stored in other areas that we see less impacted by Alzheimer's. But eventually, as the debris continues to build up, these amyloid plaques continue to build up, even those get disrupted in the person's ability to kind of pull that information out. So it's what you see here on the screen, why the people have the symptoms they do.
What about um, being accusatory or anxious? And how can loved ones respond, or how should loved ones respond when when that person is being accusatory or seemingly very anxious? And why does that happen?
Just before Dr. Sanders answers that, let me just point this out. When I run into patients, I have to explain to them this what she just mentioned. And I've used a slightly different analogy, and that is, but she has it perfectly on the screen. And that is that these nerve cells not only contact one nerve cell, but many nerve cells, okay, to help allow the storage for memory, okay, and for functionality. And as you can see here on her screen, these amyloid plaques, they kind of get between where the nerve cell is sending out that message to those that receive that message. And I tell people to look at it as if you got some kind of electrical instrument that runs on electricity, but if you interrupt that electricity, there's a shortage in it. Sometimes the electricity go through, sometimes it does not. It's kind of like a fan that you got, running, and you step on the cord, and all of a sudden that fan slows down. That message does not get through. So that means it may not get stored as we hope that it will get stored. Bottom line is what she's saying, and that is these plaques interrupt the message from one neuron to a bunch of other neurons. Not just one other nerve cell, neurons being nerve cells. Not just one other neuron or nerve cell, but a bunch of other neurons. And then overall, you wind up having the capacity not to transmit information amongst nerve cells.
Exactly. Exactly. But to answer your question, Joycelyn, there are a lot of other kind of non-memory symptoms that come along with Alzheimer's that I failed to mention before, and that's the personality changes, the agitation, And that makes it very difficult for the caregivers of patients with Alzheimer's. They become delusional. You moved my purse and put it over here, even though you've not even been in the house all day, or accusatory. And so there's not one perfect tip to have to suggest in a situation like that. But what I do tell patient and their caregivers, or the caregivers, is to pick your battles. My ultimate goal, and I'll talk about it towards the end a little bit, is safety and quality of life. Is what's happening safe for them, and is it impacting their quality of life? And so you don't necessarily have to make sure the patient knows that they're wrong, or make sure your loved one recognizes that they forgot something. If it's a safe environment, if their quality of life is unaffected, and they move something, just say, I apologize for moving your purse. I thought you needed it somewhere else, even though you didn't move it, right? Because what happens is you go back and forth, and that raises anxiety, and that raises the agitation. Unless the situation is unsafe, right? They are wandering or leaving outside the home, lost and confused, or if they're cooking and leaving the stove on. Those are instances where you want to intervene and kind of help with that. But ultimately, it's a reassurance. It is making sure that they feel that they're heard, and that their truth is knowing that their truth is their truth. And finding ways to redirect them to help with some of that agitation and the accusation, as long as, again, it's safe and their quality of life is preserved.
I'm glad you said that because, sometimes as caregivers or family members, we get irritated because we are being accused of something that we didn't do, but we have to recognize that the person is not well or normal, although they may mimic behavior of before. And some family members will say, oh, they know what they're saying. Like, yeah, no, not really. You know
Yeah.
what I mean? And maybe they do, but you have to recognize it's the disease. And I'm glad you raised the point of going back and forth with them makes them more anxious. And then the situation could really spiral out of control. If you're just tuning in, we're having a conversation with Dr. Kalina Sanders, a neurologist here in Northeast Florida. We're talking about dementia. And one thing, if you didn't just tune in, if you've been on the entire show, Dr. Sanders talked about dementia being the parent. That's the way I look at it. The
Mhm.
top of the chart, if you will, and then all the different parts of the brain that are impacted. If you have a question, please post that now so that you can get your comment in or question in with Dr. Sanders. So, what does a realistic person centered care plan look like in the first 90 days after diagnosis?
Before we get to that, Joycelyn, I do want to talk about what is the pathway to get to that diagnosis, right? If you have a loved one that you're concerned about, how do you get them to the diagnosis? And it involves, a clinical evaluation and screening. As Dr. Kane mentioned, oftentimes that starts in the primary care office. I know they have annual visits where a cognitive screening test is done to help pick up some of those things. He's mentioned other ways his office staff has been able to glean some information from that. So that's oftentimes your first step. And then that your primary care doctor will oftentimes refer you to a neurologist where we can do additional screening tests. Although I do tell people that my screening test is not that much different than what the primary care doctor has, but I can take that information and kind of tailor it into next steps. And what are those next steps? That next step might be a more formal assessment, and that's done by a neuropsychologist. And that is a fairly extensive, comprehensive evaluation of all of those different aspects of cognition and thinking and memory that's done by a neuropsychologist. That takes about 3 hours or 4 hours to do. So you have to be prepared for that test. But it can be helpful for us to distinguish between, is this Alzheimer's? Is this vascular dementia? Is this depression? So sometimes mood disorders, even in the elderly, like depression and anxiety, can mimic dementia. So it helps us to be able to tease out and determine, are we dealing with something like Alzheimer's, or are we dealing with something like attention deficit or ADHD or depression? Then the next step might be, after that test, we might do imaging. We will look at the brain with either an MRI or a CAT scan. And that CAT scan and MRI is looking to see if you've had multiple strokes, to see if you had a brain tumor or bleeding in the brain, some other cause for the symptoms that they are exhibiting, to rule out those other things before we settle on dementia. I generally tell my patients that we can't see dementia on an MRI or a CAT scan, but they're helpful to rule out other things. Then, if we get that there's clinical concerns, the memory tests should suggest that this is Alzheimer's. We now have the availability to do a PET scan, which up until probably about a year and a half ago was not covered by Medicare. Now there are pathways to get this PET scan covered that helps us to investigate whether or not someone has amyloid plaques in the brain. So this was the first time that in the last 1 to 2 years that we could visualize amyloid plaques by looking at a specific tracer. And so we have PET scans now that can confirm that someone has a large number of amyloid plaques in the brain that could correlate with their symptoms. And then there are labs. That could be a spinal tap where a needle is poked into the back and fluid is drained to look for markers of Alzheimer's. And then there is a blood test. I don't know if anyone has heard, but it was in the news. It was on every TV commercial that came through my screen about the FDA in May approved the first blood test to help with the diagnosis of Alzheimer's disease. And so there is a lot of breakthrough that's happening and helping us to identify who is at risk or who is exhibiting early signs of dementia or Alzheimer's without having to put them in a PET scan machine or take spinal fluid out of their back. So there is a test that's now FDA approved and available at Quest, where we can draw the blood and determine early on if someone has amyloid plaques in the brain. This blood test, though, is indicated for people above the age of 55, so adults who are exhibiting signs and symptoms of the disease. Right now, the FDA has said this is not for general screening. It's not one of those tests that if you hit a certain age, you automatically get it. That it has to be in the context of symptoms that are concerning for a cognitive deficit. And so it is felt that this blood test correlates very well with the PET scan. It's a much cheaper test. It's a much easily accessible test. And so we're going to see where it continues to go over time. But with the all that evaluation, we're able to finally get to as much of a diagnosis as we've been able to in the past.
Let me
Wow, there's
say
a lot
one
of
thing.
steps. It's a
One
lot of
thing.
steps.
The term I need
And
to run down is one thing, and because I'm a primary care physician, I know these patients do is, well, doctor can't run the test. Sometimes what we run into is some of these insurance companies
Mm-hmm.
reject me trying to order the test. And so then I have to do a roundabout a way of trying to get that done and have to refer to our neurologist, which then delays a lot of time because, as Dr. Sanders said when she first got on, they're like 105 days out in terms of scheduling appointments. So we're looking at 3+ months before I can even get the test ordered because of the requirements from the insurance company. So and I'm not trying to defend myself as much as I'm trying to defend all of primary care and advocate for those patients that look, they need to cut this out and allow us to be able to test for it. And because they say it's not a generalized screening test, that's the excuse that some of the insurance companies run past everyone to not
Mm-hmm.
order those tests. So, and I think I'm I'm not a genius. I think most of these other primary care guys know it. But the difficulty that we run into in terms of ordering those tests, a lot of times it's from the resistance or the kickback from the insurance agency. Now, I said all that to say if your primary care advisor lets you know that I couldn't get that test covered, now it's time for the family to advocate on behalf of the patient.
Mm-hmm.
Exactly, exactly. So previously, as I mentioned before, the PET scan and the tracer that's used for the PET scan is like a $3,000 tracer, right? So
Wow.
the insurance companies are like, hold on, wait. There are 2 million people in the country that could have this, and that's a lot of money, right? That we have to spend on this. So they have changed, some of the insurances have changed some of the guidelines and in situations in which they are allowing the PET scan. So we get it the same, Dr. Kane, is that, the patients and the families coming to us and we want to order this test. And the insurance company says, well, have they had a neuropsych testing? Have they had ruled out B12 deficiency? They have all these criterias that's required. And even with the PET scan, they don't allow, a lot of insurance don't allow it for screening. So it's a test that's used to determine if someone is a candidate for the newer medications that I hope we have time to jump into
Oh,
before
we
we
would.
end it. So the PET scan can only be approved if you're considering those other medications. And so they've gotten a little tricky for cost containment. But I think with this blood test, obviously it's a much cheaper test, probably more widely available. Again, you can now, as of last week, get it at Quest. You write the order like you do any other blood test. So that might open it to primary cares that can get this test approved or get this test done for their patients.
So, which therapies or lifestyle changes have the strongest evidence for slowing decline or improving quality of life?
Yeah, so we have we've had a number of treatment options, pharmacological treatment options in the past that really haven't really changed the scope of the disease or the process that happens. So I don't know why my screen looks all jumbled, but many people have seen or used donepezil or Aricept, rivastigmine, memantine, and these were all considered symptomatic treatments, which mean they don't change the underlying process. They don't impact those amyloid plaques. But as of last year, almost like the week after I was on the session a year ago, we got our second FDA approved medication. So now we have two medicines that are deemed as disease modifying treatment. What does that mean? is that they potentially slow down or delay progression in people who have mild cognitive impairment or early dementia due to Alzheimer's. I will say that there does come a stage in the disease where the disease process is more advanced, that these medications have less effect. So the earlier the diagnosis means the earlier we can potentially use these medications that changed the disease course. They are infusion medications, which means they go into the vein. And so they have to be given at certain facilities. The Leqembi, the one on the left, is an infusion that is given every other week, so 2 times a month. And Kisunla, the one on the right, is an infusion that's given once a month. So in patients who have mild cognitive impairment, who have early dementia due to Alzheimer's, and they have a positive PET scan. They have to show evidence of a positive PET scan to be a candidate for these medications. So that's where that diagnostic pathway comes into play, is how do we get to these medications? I think it's important to know that they slow the disease down, but they don't stop it and they don't reverse it. They don't make it better. So when we look, and this is more for any physicians or clinicians that are on the call, but when we look at what happens in patients who are on placebo, so the natural history of the disease is that this gray line, they decrease over time their function. The pink line is the Leqembi. So that group does decrease, but they have a less of a decline over time. And this is a 18-month period. The same thing with Kisunla, which is on the right side. There's about a 22% slowing versus placebo. But I think it's important that the patients know and their family members know that even though these medications go in and clear out the plaque, they go in and clean it all up. And people at the end of the trial and after 2 years have very little amyloid plaques in the brain. They don't stop the disease and they don't reverse it. They just slow it down. But we have to balance this potential effectiveness with the potential side effects. And one of the potential side effects for patients who receive these medications is a condition called ARIA. That's amyloid related imaging abnormality. So when these medications go in and clear out that debris in the brain, there are some people that will either develop swelling or edema, or they can develop bleeding in the brain because of the medication. Most people, it doesn't cause any additional symptoms, but serious symptoms can occur and it can be fatal for some people. But the majority of people, this imaging abnormality is asymptomatic or doesn't cause any symptoms. And so there are some people that have a genetic abnormality that increases their risk for having this ARIA. And so, because of that, if we are considering one of these medications, we are doing genetic testing or blood work to look to see if what your risk is. And then these medications also require frequent MRIs in the very beginning. So, for instance, for Leqembi, you have to have an MRI before, you have to have an MRI before your third infusion, before your fifth infusion, before your seventh infusion, and I think before your 14th infusion. So it does require frequent MRIs, which I think really poses a socioeconomic burden on people that are from lower socioeconomic areas, and people that are uninsured or underinsured will have difficulty not just accessing the doctors, but accessing these medications and all of the assessments that are needed to proceed with these. So MRIs are needed, but people can also experience infusion reactions as well as headaches. So when you have this discussion with the neurologist, is probably where you're going to be, is you want to know, what medications are available? Is my loved one or am I a candidate for these medications? What are the potential side effects? And what is necessary for me to be maintained on these medications? And have that discussion and be knowledgeable about what you're stepping into. I think it's very exciting that we have these options that are available, but we make sure that we do it knowing everything about them.
One of the biggest in the excuse me, term, but some of my patients are looking at using these medications or have been prescribed, but of course they come back to me and ask me, "What's your opinion on it?"
Mm-hmm.
One of its most serious side effects is what you mentioned, the macrohemorrhaging in the blank brain. Okay,
Mm-hmm.
that associated with like leukemia, whatever, um, associated with those particular medications. The difficulty for me as a primary care physician is noting that if you're on these medications, there's a very intense follow up that is needed for those patients to continue participation in those particular treatment, uh,
Mm-hmm.
the treatment design. And again, I go back to macrohemorrhaging, and because the requirement with the macrohemorrhaging is maybe that if you suspect the slightest thing as far as it relates to having strokes or whatever it may be, that you need to make sure that you're available to the prescribing physicians because they understand what you're up against. So, some of the questions I run into sometimes is, well, my mom has family in New Orleans and she visits frequently. And so, because she visits frequently and the potential for bleeding in the brain, what happens if she gets to New Orleans and demonstrates some episode of something neurological? What do we do at that point? And that's been the most difficult question that I have to answer those patients. Anything to give me some assistance in that?
So that's the difficulty with using these medications, is balancing that. And so I would tell them to obviously contact their neurologist or whoever's prescribing it. But if they are away from home and they develop symptoms that would suggest that there's bleeding or swelling, which could be any stroke-like symptoms, it can be weakness, numbness, confusion, uh, double vision, then they do need to go to the emergency room. Wherever they are, they need to go to the emergency room, which again adds on some of what this screen here shows in that bottom left corner is like some of those treatment risks. What are the high test and visit burden associated with the medication? And then the high financial cost that comes along with it, right? So you have copays for MRIs, you have copays for other assessments, so you have to take that into account as well. But yes, so for physicians or primary care doctors who are co-managing patients that are on these medications, is one, being aware that ARIA is a potential side effect, and when to direct people to the emergency room for an urgent MRI.
And making sure that physicians are alert I mean, making sure the patient alert those treating physicians that they are on this medication. So they may need to make sure they got someone with them. Because remember, they got dementia.
I was
Yes.
thinking that. I was thinking that, Dr. Kane. Yeah.
I figure as
Um,
much.
but even but even some of these people on the medication could have mild cognitive impairment, so they're not quite to the point of dementia, and so they may have the wherewithal to understand this concept. And so, yes, making sure that the patient knows, the family knows, every physician they encounter on a regular basis knows that they're and are familiar with these medications.
When you talked about medications earlier, and I can't remember the name of the one medicine, donepezil, that's what it is. As an example, if a person has been on that for 2 or 3 years, and you can and the disease is progressing, does it really matter if they continue that medication or not? Because it's really not slowing the disease or stopping the disease. And particularly in the case of someone who might be elderly, is it really necessary for them to continue that medicine?
I say no, it is not. But you should have that discussion with your the neurologist or the prescriber of it, just to make sure that everyone is on the same page. But as I mentioned before, those amyloid plaques, the debris in the road, keeps building, and medications like donepezil, memantine, they really just help the healthy nerve cells to communicate better. That's why they're
Okay.
called symptom medications, because they don't change the underlying process. And then there does get a point where that debris wall gets so high that they can't facilitate a communication. And that's when those medications should be stopped, because that's one less pill or three less pills that a person has to take. They themselves are not without side effects as well. So we definitely want to make sure that our loved ones are on the most appropriate treatment, that's actually helping them. But yes, there are stages of the disease where those medications are not effective
And I
and
like
could
that
be.
next slide, Dr. Sanders, as we don't like to, we like for you to get home with your family. So if you want to
Yes,
speed it up, because we
I
are a
got
little
you.
bit
This is
past
the
the
last
hour.
slide. Yeah. Oh, this is the second to last slide. But I will say non-medication management. We mentioned over again that really that healthy lifestyle is important. That you're eating, you're getting the nutrients that you need. As a person is moving through their stages of dementia, I think it's important to know that they should be planning for legal implications as well as financial implications of the disease, and have that discussion with the family members as early as possible, while they can engage in activities like power of attorney, healthcare surrogates, so they can be aware of who they're giving those roles to for the future. They also, after the diagnosis, want to start to build their care team, making sure the necessary people are in line to help you, the primary care, the neurologist, maybe the speech therapist for cognitive rehab might be a part of that team. And then a plan for increased caregiver support, particularly for ADLs and for the patient. And then also looking further down for caregivers is their caregiver support, whether or not they have respite care, whether or not they have additional resources to support them to take care of their loved ones. And I'll give a shout out to obviously the Alzheimer's Association. Their website is phenomenal with providing that type of information and those resources. And then we have someone local in our community who wrote a wonderful caregiver book to help people, caregivers, along the path of the different symptoms that their loved ones may be exhibiting, to help them facilitate how to get through it. So Monica Hardy lost her dad from Alzheimer's a few years ago, and she's has this wonderful workbook that you can write down and help you facilitate taking care of yourself as well as the patient or your loved one. Sorry.
That's awesome because you're right. Caregiver support is so important because it is a lot for people to deal with. I was talking to a friend and she was telling me about a friend of hers that the mom used to just have fights with her daughter, put the
Mhm.
daughter out the house. She just got very aggressive. And that's a lot for someone to have to deal with.
Mhm.
They don't want to leave the house because they obviously want to care for their loved one. However, when your own safety, health and safety then becomes an issue, that's also when the family has to make the tough decision that it's time. People try to keep their loved one in their home as long as they can, but then there's a point where they have to move them to a facility. This is a very
Mhm.
complex topic, Dr. Sanders and Dr. Kane. We didn't even touch on what now when you have to make the decision. Those things you talked about in the slide before, having the care team, legal issues that you need to take care of, a business that you need to take care of. People just don't know the complexities associated with the disease in caring for their loved one. Again, once you get past the okay, I recognize that my loved one does have the disease, and thanks to Dr. Hardy for writing that book, then what? Right?
Mhm.
And going and another person that I thought about when you talked about building your care team and healthy lifestyle, Dr. Kane, I thought about our resident dietitian. Like, when do we need to bring Linda in to the discussion to talk about, are there any particular foods that we need to make sure, any nutrients that they might become deficient in, that we need to make sure that they have as a part of their regular diet. So, speaking
The
of
thing
care,
for you
Dr.
see,
Sanders, what three actions should a caregiver take to reduce stress and risk of crisis?
So really, one, identify what those triggers are for that crisis. There may be certain situations where they become familiar with the patient. If X happens, I know this is going to set them off. Obviously, looking for signs of infection because that might be another reason that throws their loved one off.
Mm,
And then have a plan. What happens if? So I mentioned Dr. Hardy has her book, and she has some tips of things that you can do in the event that we need to flip the script in a sense for our loved ones and make sure that we can calm them down, redirect them, or kind of get them out of the situation. And then three, pick your battles, right?
yeah.
Determine which ones you're really going to fight for.
Right. Don't have an argument about something you know the person is wrong about, right? Just let it go and like, oh, okay, yeah, really? Yeah,
Yeah.
because I've had a relative who will speak of relatives who've gone on to glory, and they were like, no, I just talked to him yesterday. You did? Oh, okay. Tell him I say hello the next time you talk to him. Even though you know that that person is gone on. What Dr. Sanders, you've been great, wonderful as usual. Just it's just again, this is a very complex issue. It's something that the caregivers, loved ones are just in so much denial. It's just hard for them to see their loved one. But we do like to give our guests an opportunity to share their final thoughts. So, what are your final thoughts that you'd like to leave with our audience tonight?
I think Alzheimer's, as you mentioned, is a common disorder that will affect someone in your family. It's just a matter of time and age, and so understanding the disease is important. Getting them to the appropriate screenings, starting with the primary care doctor, going on to the neurologist, and then asking the questions about what treatment options are available and understanding their benefits and their risk is key. And then doing everything as we just mentioned to support and provide resources for the patients so that ultimately they are safe and they have the best quality of life.
Thank you so much. And Dr. Kane, what are your final thoughts?
first of all, I want to really, really show much love for Dr. Sanders and coming on and addressing this very complex topic that we barely scratched the surface with. As we've always said, If you give 1 hour, it may need 3 hours, okay, in terms of discussion. And definitely, this is one of those subject matters that need 3 hours of discussion because there's a lot of stuff that I know that Dr. Sanders, because of our limited time that we gave her, would like to discuss some other things. But again, you can't do it all in one night and not be here to midnight. Okay. So, but the other thing I'd like to make sure that we all understand is that the dementia is a very complex topic. Okay. There's no one, there's no universal approach to dementia that will address everybody. It has to be tailored to the individual. You know, the person has high blood pressure and diabetes and elevated cholesterol, then you know, you can't just assign it to Alzheimer's. It may wind up being a vascular dementia. Okay, even though 60 to 80% of the time it is Alzheimer's. Okay, in terms of what you're dealing with. So the keys to trying to help a loved one get through this is making sure that we can do as best we can to get the right diagnosis so we can do the right approach to how to treat your loved one. If we determine what the particular disease process is, then we need to make sure that their primary care and or depending on the stage of their therapy or their neurologist is in tune with what you and your loved one that you're getting treated are up against, the things that they're up against, and see how best they can help navigate this disease. Because it is not easy in the least little bit. There may be treatments that are out there that have their own ill toward effects, as we may say. And so we may need to be aware that is that beneficial for my loved one at the stage that they're in versus not being beneficial or more harmful to them at that point in their life. So, you know, you got to find the right clinician. You hope to find the right clinician to help address these issues. And as much as I love some of my other neurologists, a lot of times when it comes down to taking care of people that look like you,
Mm-hmm.
is preferring them to people that look like you.
Mm-hmm.
So they do understand your culture, okay, and the things that you run up against. I'm not saying we're the only ones to be able to treat them, okay, because there's not enough of us out there. But
Right.
if it's possible, make sure you look at the people that look like you and understand, you know, you could be my mama, you could be my sister, you could be my
Mm-hmm.
brother. And that's what I'm running into, you know, in terms of taking care of these patients. And the last thing that I'm going to say, there are multiple treatments out there. Some of them are so bogus till it's not even funny. But you want to choose what's best for you and your loved one because even though there are medications out there available, they do still need proper follow-up and proper guidance in terms of administrating and dealing with these medications. If you're not able to do it, you may be doing more harm in a short term or long term, whichever way you want to look at it, than you are doing benefit. So, you know, recruit other family members, get some help to be able to take care of your loved one. Wife, sister, mother, daughter, whomever it is, you can't do it by yourself. Even though you want to be valiant and try to do it, that's very difficult
Mm-hmm.
uh, path by which you can participate in taking care of that loved one. So get somebody who can help you, willing to help you, okay, and understand what you're going through. Dr. Sanders has demonstrated that over the many 15 years, still a baby, uh, 15 years that she's been in practice. She's demonstrated that, but she's demonstrated to the level that she is so good at what she does, seek someone like Dr. Sanders to assist you. It's just that everybody else is trying to do the same thing. That's the work part of it. So with that, I'm done.
I love it.
Thank you again.
I'm going to interject just a little plug in for Baptist Neurology. I probably shouldn't do this, but I don't know if you're familiar with Dr. Christine Pierre. She was in the Orange Park area, but she is another Black female neurologist who joined our practice here at the beach. And she's another great resource to help, people in our community, because it really, the biases do exist. And it does make a difference when someone can relate to you, and we change our thinking process sometimes. Maybe we're more protective, less cavalier, with people that we relate to. So just a plug in for Baptist Neurology here at the beach. Come see us.
Christine Pierre, you see, right? Pierre.
Yep.
Okay. Yeah.
Yep.
Thank you, Dr. Kane, and thank you, Dr. Sanders.
She was with HCA, Orange Park, but now she's with Baptist.
Thank you, Dr. Sanders, for sharing your expertise and heartfelt insights on what it truly means to live with dementia, not only for those diagnosed, but also for the families and caregivers who walk alongside them. Your guidance tonight reminded us that compassion, awareness, and early action make all the difference. To our listeners, thank you for pausing with us for this important conversation. Remember, dementia doesn't just touch individuals, it impacts whole families and communities. Together, we can break the stigma and build a stronger circle of support. If you found today's discussion valuable, please share this episode. And don't forget to tune in next week. We're going to be, it's Prostate Cancer Awareness Month. So we're going to switch and go to another part of the body. And we're talking about prostate cancer awareness with Dr. Christopher Williams. And make sure that you subscribe to our YouTube channel and visit our website or go on our YouTube channel to look at past episodes. Dr. Sanders was on last year. And so the more we get this information out, the more we want you to help us get this information out. Thank you. Good evening. And tune in next week for Pause for the Truth.
We appreciate you spending time with us on Pause for the Truth. Ms. Jocelyn Turner and Dr. Rogers Kane are grateful for your support. Don't forget to like us on Facebook, catch us live on Twitch, and most importantly, subscribe on YouTube. A big shout out to Tyrone Jackson at Call Tyrone IT Services for keeping us connected. Join us every Tuesday at 6:30 p.m. Eastern Standard Time for more enlightening discussions. Thanks, and see you next week.